Welcome to the International Journal of Paramedicine podcast. I'm Mick Gunderson, the editor-in-chief, and I have Dr. Peter O'Meara joining us for discussion of a manuscript appearing in issue number 11 for July-September 2025. The manuscript is entitled Integrating Community Paramedicine Topics into Degree-Level Paramedic Education Programs, a Strategic-Pragmatic Approach. But before we get into the interview, I want to let you know that for many of the manuscripts published in IJOP, it marks the start of a discussion on that topic within the paramedicine community on the NEMSMA email listserv, which is hosted on Google Groups at groups.google.com/G/NEMSMA. So after you've watched or listened to this podcast and read the manuscript, go to the NEMSMA listserv to ask questions, make comments about this or other papers. We really want to get you and other paramedicine professionals at all levels engaged there in scholarly discourse for the advancement of our discipline. You should also know that our editorial team will curate the best parts of these email discussion threads for inclusion in the dialogue section of the journal, which is our version of the traditional letters to the editor section. If your question or comment is selected for the dialogues, you will be officially cited. So please join in and make your voice heard as a paramedicine professional. So here we go with the interview. Welcome, Peter. Thanks for joining me here today.
Thanks, Mick. It's nice to be here.
Well, to get things started, can you tell us a little bit about your background?
That goes back a long way. Currently, I'm an adjunct professor at Monash University and also at Charles Sturt University, both in Australia. I also on a couple of boards in the US, including the American Paramedic Association. And previously, I was an academic for about 20 odd years in various universities in paramedic programs, and before that in rural health programs in general. My earlier life was as a paramedic, and I worked in various roles from a trainee right through to being a superintendent, which is sort of like your version of a paramedic chief, I suppose. And done a lot of study along the way.
Yeah, I've certainly seen your publications many times over the years, so very well published. But to get to the particulars of this manuscript, tell me about the particular problem or issue that you and your co-authors were trying to address with this project.
Well, this project was about paramedic education in community paramedicine, and as most of us know, community paramedicine has battled to define itself. And as a result, we've ended up with lots and lots of short courses to fill the gap. And this has happened worldwide. So we've gone off in many different directions. And our objective in this project was to try and synthesize that a little bit and harmonize the curriculum so that you could say, oh, I've done a community paramedic program in this particular country or this part of a country, and it would mean pretty much the same thing. So we tried to do that to make sense of it all. This particular article was an output of that, where we came to the conclusion that community paramedicine doesn't just happen in a distinct program, it happens across the board. Paramedics see patients with chronic primary care conditions all the time, and it doesn't matter whether they're in a program or not, and that it really should be in the basic training. And so we've matched that to different levels of training. The first is the certificate level, which is pretty much what you do in the US. And then we looked at the degree programs, because much of the world already has degrees for paramedics, and looked at how you might put that content from community paramedic programs into a degree. And that was the focus here. We didn't really look too closely at postgraduate programs because it's not relevant to a lot of people, and it's such a fast moving area that, as soon as we wrote it, it would be out of date, because that's still very much being developed. So it was about trying to marry the multitude of courses into people getting some academic credit. And as you know, in some parts of the world, paramedics do lots of training and lots of courses and get absolutely no academic credits compared to their peers in other health professions. And that seems unfair and unjust. So we're trying to make it so that whatever we recommend is compatible with a higher education system.
What struck me about the paper as well was the methodology you employed. Could you explain that a little bit for our viewers and listeners?
We really used a multiple approach. We looked at some existing paramedic programs, and we used one in particular from Paramedic Health Solutions as a sort of a core one, which it was very similar to lots of others. So we looked at that particular one. We looked at the literature to see what was written about community paramedic education. And there were, there's a reasonable amount and there's bits and pieces, but there's lots written in the literature about community paramedic service delivery, but not a lot about education. But we found enough. And the main thing we did, we recruited people to be on panels, expert panels from around the world. I think we had people from 6 different countries where community paramedicine's either emerged or emerging. And we asked, I think, 65 experts to participate, and a little over half put their hand up and answered the questionnaire in the first round. And what we asked them to do was look at an existing curriculum and say whether they agreed or disagreed that this was relevant. So that was fine. If you ask someone to say, are the social determinants of health relevant to community paramedicine, yes or no. And then we asked them to comment on the strengths and weaknesses of what they saw. After they'd replied to that, we went away and did some more work and came up with a draft curriculum. We then sent it back to the same people, and, a reasonable number of the people involved also replied the second time round and asked them to basically criticise what we'd written. It was all very well putting up someone else's curriculum and saying, pull this apart. And, on the whole, they weren't that critical. But we did the same thing with our own, and they came back again and told us what they thought. We then did some more work and, a lot of detailed work, which doesn't all appear in the article, I must say. Your journal's not that big, even online. We then had a second panel, a much smaller panel, of people who were sort of super experts, and asked them to comment. And they looked at it and they made some really valuable comments too, but essentially they validated what we'd done. And then we wrote a report, which is available on Amazon, on community paramedic curriculum. And then out of that, we've written a couple of papers in the areas that we thought were interesting, which in this case was about how to integrate community paramedicine topics into paramedic degrees.
Sounds like a very thorough process. A straw man initially. Everyone commented. You incorporated their comments into the second round, polished it up again, and then submitted it to the final panel of the super experts to generate the finished product. Very, very methodical, straightforward. Congrats on that. Given that process, what were your main findings? What did you really? What were the takeaways or ahas here?
Well, the way we asked the questions, we just asked them what they thought of the original curriculum and along the way. We didn't say, should it be in a degree? We never said that at all. That was not in our wording in the early stages. That suggestion came back from the participants. So what they basically said was that the straw man curriculum, as you say, we put it up and people basically agreed that the topics were okay. They were pretty spot on. There was a bit of debate. There was one topic about COVID, and people came back and said, oh, yes, but it's too narrow, and, really should be looking at all infectious diseases and public health and things in a broader sense. So that was the sort of criticism we got back. We also found that, depending on the country people were from, they said, well, we already teach this in our degree programs, which is, understandable, that it's nothing new. So that they're saying, well, why would we do this in a community paramedic program? Because we've already done it. It's sort of ho-hum. Whereas others said, oh, absolutely, we need this. So we sort of took that on board. One of the main things that people said was, we like the topic, but you've allocated 4 hours to it. It should be a whole semester and some real depth. And thought, well, you're not going to be able to do that in a short course. But we live in a real world. So how are we going to do that? So it sort of evolved into, well, let's look at a certificate course first, which was very much a generic community paramedic program, very similar to what's been done in the US and Canada, where you do what's a community paramedic program, how do you organise it, that sort of thing, some of the assessments, and then do some practicum, supervised practicum. That was pretty much the course. And then we thought, well, how do we get this extra depth apart from those two subjects, which are pretty obvious? And we looked at existing degree programs, mainly Australia, but also a model degree program from the UK, where the College of Paramedics there has actually developed sort of a template for a degree. So we looked at them collectively and picked out the subjects that actually did cover community paramedicine, like public health and related issues. The big gaps that you would see in the US that paramedics are always saying, I didn't get enough training in this if I got any. Things like mental health. Because I know in Australia, more than 20% of all patients paramedics see are mental health patients. But traditionally, we didn't receive much training at all. So while we're saying it's a community paramedic focused piece of work, we're also suggesting that, well, all paramedics should do these subjects and not just be stuck with just doing acute patients and acute training when massive amount of the presentations are actually primary health care and chronic conditions. Being old is not in some ways not a medical condition, but it's what paramedics see. They see old people, they see people with diabetes, see people with mental health issues, mobility issues, that sort of thing. So that's an everyday occurrence. So yeah, we just suggested that they should be part of it and that paramedics should get proper recognition and qualifications for it, which of course then, we're getting into the argument about degrees, but it gives paramedics access to postgraduate education. It gets them in the door, it gets them to be part of research teams and so forth, and in a sense take charge of their own profession.
Yeah, no, that makes perfect sense. I've always thought that the community paramedicine idea is something that just should be woven into the fundamental training curriculum of all paramedics, and that seems to be borne out by the conclusions you just cited. Someone who's going to work in a dedicated role with follow-up care rather than doing primary emergency response, of course, will have a little bit different workflow and scope of practice, but absolutely there's such considerable overlap. But now that this is out, you've got the main manuscript out there, as you mentioned. We've got a couple of the papers, including the one that we're publishing here in the International Journal of Paramedicine. What impact do you hope that this work will have on the paramedic degree program curricula?
I think it depends on which country you're from. And in the paper, we explain, uh, we use a model that one of my former PhD students developed, where there's really, within the Anglo-American paramedic system, as we understand it, there's really two models developed. And one is more of a traditional model, which is what we've called a directive model, where paramedics are working under the control of another health professional. And, really you're licensed by a licensee, and predominantly medical doctors, and that your scope of practice is sort of limited to your protocols and you don't have a lot of autonomy. Now, I know that in reality, the on the ground experience is often different to what's written on paper too. So don't get me wrong there. There is a reality going on. But that's at one end of the continuum, you've got this directive model. And the type of training you need to be a community paramedic is a bit different in that sort of model, because you're not running the model, you're not evaluating the model, you're not making most of the decisions. Whereas at the other end, you've got an autonomous professional model where paramedics, the basic paramedics, have degrees and they are expected to make their own decisions and act autonomously, and also build on those qualifications, become advanced practitioners, more akin to a nurse practitioner, for instance. And that requires people to do a master's degree and all that sort of thing. And it's well developed in the UK, and it's starting to develop in Australia and New Zealand, where that's happening. So you've got those two ends of the spectrum. So developing the degree in the US and those other countries with directive areas, it's important for people to understand what can be in a degree, because I saw a comment on social media only yesterday where a doctor said, well, there's not enough content to make up a degree for a paramedic. And if you only look at the really sharp end, acute part of it, that person may be right, but you're only talking about 5% of the patients. But if you look at the patients that actually present and the work that paramedics actually do, there's more than enough content to put into a degree. I probably need to explain that in the UK and Australia, New Zealand, and I think also South Africa, degree programs are 3 years, not 4 years. And the difference is that you spend a year doing general studies of that 4-year degree. We don't do that. We do that at high school. That's already done. So we're saying, for the purposes of this exercise, a 3-year degree in one part of the world and a 4-year degree in North America is pretty much the same thing. But it's getting people to understand that a degree is more than just learning how to put a needle in or to shock someone or give a particular drug. There's much broader topics that need to be learnt. Things like law and ethics is very, very important to learn and understand at all levels. So it's trying to make the degree relevant in places like the US. In the other countries, there's already degrees, but they're absolutely chock full of acute medicine, if you want to call it that. And there's not a lot of room left for the public health type primary care subjects. And that's a bit of a challenge for everyone, to sort of try and get a more balanced curriculum that better reflects the reality of what people see each day.
I think that's absolutely key. Match the curriculum for the types of patients we actually see rather than that 5 or 10% of the high acuity cases, which is where a lot of the curricula is focused now. So wonderful work, Peter. Congratulations to you and your colleagues on not only this paper, but also the other work that has been published with this basic project. Thanks so much for joining our podcast. So I want to remind everyone before we finish up, if you haven't already done so, read the full manuscript in our July-September 2025 issue of the journal. You can ask questions and make comments about this paper on the NEMSMA listserv at groups.google.com/G/NEMSMA. Get other IJOP videos added to your feed by subscribing to the IJOP channel on YouTube, and you can listen to this content on your favorite audio podcast platform. So on behalf of the National EMS Management Association and the entire journal staff, thank you so much for listening.